Slides are moving. Keratoglobus is a rare, non-inflammatory corneal thinning disorder characterized by generalized thinning and global protrusion of the cornea. Can be congenital or acquired. Congenital form is always bilateral and associated with systemic conditions like Ehlers-Danlos, blue sclera, osteogenesis imperfecta, etc. Whereas acquired may evolve from a pre-existing pellucid margin degeneration or keratoconus. My aim is to describe the outcomes of limbal sparing lamellar keratoplasty for the management of advanced corneal ectasia. It was a retrospective case series with 3 years of 3 patients with acquired keratoglobus and 3 years of 2 patients with congenital keratoglobus and Ehlers-Danlos syndrome. Before surgery, all the patients had documented progressive corneal thinning. Coming to surgery technique, all the procedures were done under general anesthesia. Horst cornea was marked 1.5 to 2 mm inside the limbus. A 360-degree peripheral corneal lamellar dissection was done, extending beyond the limbus and preserving the limbal stem cells. The corneal periphery along with the dissected limbus and conjunctiva cut into 4 flaps and reflected. Epithelium was debrided. The donor tissue of about 12 to 14 mm was prepared from a flesh whole globe or a corneal button. Decis membrane was stained and peeled off. The donor graft was positioned and fixed to the Horst scleral groove using interrupted 10-0 nylon sutures. The retracted Horst limboconjunctival tissue was repositioned and fixed with glue 360 degrees. Post-operatively, all the patients were under close follow-up. Now moving on to each case in detail. First case is a 29-year-old female, a known case of pellucid margin degeneration progressing to keratoglobus, presented with recent onset diminution of vision. Her best scatter visual acuity was 6/24 in the right eye. Collagen cross-linking was deferred as the thinnest pachymetry was 217 micrometer. We did a limbal sparing lamellar keratoplasty, and post-operatively corneal thickness increased, keratometry values decreased from 56 to 47, and best scatter visual acuity she is maintaining 15 months post-operatively with 6.9. Case 2 is this 24-year-old man presented with best scatter visual acuity 6/36 and thinnest pachymetry 147 micrometer in the right eye and 218 in the left eye. We advised him the surgery, but since he was from Bangladesh, he refused the surgery at that visit, and during the waiting period for the surgery, he had a minor trauma and spontaneous evisceration in the right eye, which was managed elsewhere. He came back to us with left eye vision 6/36 and a right eye prosthetic shell. We did limbal sparing lamellar keratoplasty, and the only post-operative complication was interface heme, which was self-resolving, and he is now maintaining a best scatter visual acuity of 6/9, 2 years post-operatively. Next case is a 32-year-old male, known case of both eye pellucid marginal degeneration progressing to keratoglobus. He was on conservative follow-up elsewhere, and he had a trivial fall and corneal rupture. He underwent primary repair and multiple VR surgeries and ended up with a vision of only perception of light in the left eye. When he presented to us, his best scatter visual acuity in the right eye was 6/24 and the thinnest pachymetry was 57. We did limbal sparing lamellar keratoplasty for the right eye, and the only post-operative complication was interface haze, which resolved almost completely, but still it was remaining at the final visit with the best scatter visual acuity improving to 6/7.5. Next case is a 14-year-old girl, known case of Ehlers-Danlos syndrome, blue sclera, joint hyperextensibility, presented with a best scatter visual acuity of 6/24 in the right eye and 6/18 in the left eye. Thinnest pachy values were 290 in both eyes. Limbal sparing lamellar keratoplasty was done for the right eye. There was interface haze post-operatively, which persisted even at 3 years post-op, but she is maintaining a best scatter visual acuity of 6/9 in the right eye. Last case is the 11-year-old girl, sister of the previous patient, known case of Ehlers-Danlos syndrome, blue sclera. She presented with best scatter visual acuity of 6/45, with thinnest pachymetry of 271 in the right eye and 224 in the left eye. She was also advised surgery, but during the waiting period, she presented with a fingernail trauma, corneal rupture, with extrusion of vitreous and iris. We did primary repair, and following that, a tectonic limbal sparing lamellar keratoplasty was done along with vitrectomy. By the end of 1 year, the graft failed, and then we did a full thickness penetrating keratoplasty with scleral fixed intraocular lens. but this graft also failed again due to uncontrolled IOP and was taken up for re-PK with Ahmed Clocoval implantation. She is now doing well with a recent BCV of 6/24. Her left eye was also taken up for LSLK, limbal spine lamellar keratoplasty, but the graft failed and she underwent a lamellar keratoplasty later. Now she is doing better with best corrected visual acuity of 6/18. Coming to the results, there was significant visual acuity improvement in all patients except one. Central keratometry values decreased in all patients and corneal thickness improved in all patients. There was corneal haze in 2 patients which persisted till the final follow-up. Interface haze was present in 2 patients which was completely resolved, and graft failure occurred in 1 patient. Moving on to discussion, it is well described in the literature that corneal rupture can occur either spontaneously or following trivial trauma in case of keratoglobus. Similarly, in our study, there was 2 patients who ended up one-eyed following minor trauma before the surgery during the waiting period, and 1 patient who had a single eye trauma ended up with repeated graft failure and secondary glaucoma, clearly indicating the blinding nature of the disease and need for early surgical management. Various treatment options has been described, but each has, I think I have to conclude. I will conclude by saying that early surgical intervention is required before the occurrence of vision in treatment of vision-threatening traumatic corneal rupture, and limbal spine lamellar keratoplasty restores the integrity of the cornea without jeopardizing the limbal stem cells. There are limitations like interface haze, graft failure, and a steep learning curve for the surgeons. Thank you.